So I was asked, well, in myself, I was asked about patents and intellectual property and why it's important. So, clinical trials in drug development is a very risky business. And the phase two clinical trials are considered a graveyard of drug development. The chances of success at phase 2 clinical trials is about 30%. So the majority of the drugs fail in phase 2. The cost of drug development per indication could be between 100 and 300 million pounds, but could be much higher, depending on the education and the amount of work that needs to be done. In order to raise that much money, you need to have some sort of incentive for investors to say, I'm going to take my chances. It's really a binary outcome. It either works or it doesn't. There's no in between. So sometimes we do hear this criticism that, oh, Compass in it for profit. I want to tell you that if you are in it for profit, I highly not recommend to do drug development with Schedule 1 substance in the indication that all big pharma pull out of. It's absolutely crazy. There are so many other ways of making money in a faster and more fun way. So in order to incentivize investors to give us 100 to 300 million pounds, we need to somehow demonstrate to them we'll be able to pay them back if the drug works. And that's how the system of patents, intellectual property in pharma, was created. We can argue whether it's a good idea or bad idea, but that's how the system works. And when this question comes up, the question of patents and intellectual property comes up, I always think about when I visited my son when he was hospitalized for depression, and that was, it was summer, and the hospital was filled with kids, 16 to 25, who were, in it for the summer, with all of the kids were doing internships, traveling, backpacking in Europe, and things like that. And these kids were looking to get better. Emotional. So they were trying to tune themselves up so they can go back to school and have some semblance of life. So, if I have to choose between ideology and, thinking about these kids, I'll take the karma. I'll take the investment and try to do my best.
Okay, right. So I think we're going to move into the plenary question session, and it's obviously been a very full day. There's been a huge amount to think on, and obviously for most people this is an intensely important topic in the human sense, but it's also very important in a scientific sense, which feeds into doing best for people. So I think we'll welcome questions of any nature, apart from where did you get that awful suit, Professor Young, which isn't a suit actually. But do feel free to ask questions, and I'll intersperse if it flags with questions for the panel. So, over to you. Yeah, Fred.
Hold on, let me just bring you this so everyone can hear you. Katja, do you ever play with the idea of the timeline? If all goes well, how soon psychedelic-assisted therapy might be available to the public?
Yeah, we play with it all the time. So George is the optimist in the company, so he thinks it's in 2022, and we think it's probably 2023, 2025 to be realistic. It depends on how recruitment goes, and it's very difficult to predict the recruitment. Our population is very difficult to recruit.
Well, that's very
Then
interesting.
again, breakthrough therapy designation is known to expedite the approvals by about 18 months, so we're optimistic.
Okay, I'm going to ask a question specifically directed to Guy, James, and Hans, who's sitting there thinking he's not going to have to answer any questions. And this is a slightly more technical question, and it's about clinical trials. And it's about the fact that we do clinical trials on a primary outcome measure. And if the primary outcome measure isn't met, and you spoke about response and remission, Katia, if that isn't met, then the trial is deemed to have failed. There's many trials where that was just missed. And secondary outcome measures, which are very much related, and I'm thinking of 329 here, Guy, all went the correct way. But it's labelled as a failed trial. Now, especially given that this is a different type of therapy, and we heard that perhaps the benefits aren't captured best by conventional rating scales, that's going to be an important question. So let's just see what our three experts say, and then see what any other expert wants to say. Guy?
Well, it's a big subject. I mean, the discipline around choosing a primary outcome is just to do with statistical power. And the problem that if you make a lot of measures, and then you go back to your trial and choose the measure that gives you the result you want, that is effectively cheating. So what we need to do is not do that. And the most hair-shirted way of not doing that is to choose a primary outcome and stick with it. And that primary outcome in depression trials has really converged around an observer-rated score on like the Madras or the Hamilton. Now, there are many, many limitations to that, but the simplicity that it has at least has that virtue. And it means that certainly in early phase studies, you can be somewhat confident that your medication is superior to whatever you compare it with. You can compare it with placebo, you can compare it with the standard of care. Very frequently, pharma have chosen to compare it with placebo. The reasons around that are complicated, but that's the way it's been. Now, these are very artificial activities in some ways, and it means that you get you have difficulty recruiting and you get atypical patients into these studies. So their value is as an experiment, and I think they have to be corroborated by other sorts of data, and particularly in phase 3 clinical trials, that you have to show it in a larger population and at many sites. That sort of helps to keep pharma honest about what works. It is starting now to keep psychotherapy honest about what works, and in the past they weren't they were excellent at choosing and in fact cherry-picking their outcomes. And I think it's a fair discipline, and I'm afraid we're stuck with it. I think that the alternatives are just too difficult. So that's mine. James.
Yeah, I mean, we use the Madras because that's what everyone else uses, and that's what the regulators want, and because it was developed itself to be more sensitive to change than its predecessor, as I understand it. Maybe it is, maybe it isn't, but it's literally as simple as that, really. We choose these measures because they have precedent in other trials and they're accepted by regulators. Whether or not, and I suppose that one has to keep one's eye on what the ultimate goal is, and with this it's to challenge Schedule 1, because once you get the drug out of Schedule 1, a whole new vista really of potential research opens up, and in that we can probably be more creative about how we start to measure things. So at the moment we're doing it by the book for good reasons. But maybe in the future we will be able to measure a little bit more this ineffable process of therapy with psilocybin.
Okay, so to get regulatory acceptance for the choice of the scale, I think we probably are doing the right thing in going for one of the established scales. Typically in depression trials it's the Madras or the Hamilton scale for depression. There is nothing that would prevent us from using another scale, but I think we would end up in a long debate with regulators about the suitability of such a scale. And as Guy says, also it may seem as if we are trying to craft a scale that is especially adapted for the questions that we are asking ourselves. The other thing that is a challenge with this type of intervention, which is given once or a couple of times, is that it's very different from traditional antidepressant studies where the medication is given over a long period of time. So how to best follow efficacy over time. And even though we would probably rely on the established scales, it would be no simple task to design an optimal study that really captures the special experiences that we see with intervention like psilocybin.
So those are great answers. I mean, I don't think you're going to be able to get away from having a primary outcome measure. That's just probably too revolutionary. I think if you look at the Hamilton, Max Hamilton said that that shouldn't be used in drug studies because of the side effects, because it interferes with sleep and appetite and weight. So you're actually putting noise into the system. But Hans's point about, if you're giving a drug one-off and it's out of the system, that you've had a benefit and you're looking at it afterwards is a very good one. I'm also struck by two more things, in that we tend to be very critical of trials for failing the primary outcome measure in a way that's almost a reflex negativity. So there are trials where it just fails to meet the primary outcome, but other secondary outcomes which are similar, other depression scales and so on, go the correct way. But the critics say, well, that's a failed trial, But you need to look at the data in the round, I think. The other thing is I'm very struck by Elias Ericsson's analysis of the SSRI trials. Now, the SSRI trials were deemed only 50% to show differentiation from placebo in terms of the Hamilton. But if you look at item 1 in the Hamilton, which is depressed mood, it's a 90% differentiation. So perhaps a post hoc or a built-in sub-analysis of some part of the scale that's specifically about depressed mood and won't be influenced by disturbed sleep or whatever might be a useful thing to do. But it's a difficult conundrum because you have to negotiate this regulatory framework. Okay, other questions from the floor? Oh, I've got this, I should have that back too.
I'd just like to open by saying that I've got a lot of gratitude and a huge amount of respect for the work that Compass is doing. And I was thinking about there seems reminder that these drugs, outside the medical bubble, have a very rich and diverse repertoire of social, cultural, and political meanings. And in particular, I'm thinking about the sort of origins of psilocybin and its introduction into our society, and that before it is what it is now for us here, it was a Mazatec medicine, and a Mazatec community that hadn't really benefited in any way whatsoever from the popularization of what was once their most sacred plant. And I'm wondering if there's room in the business model of Compass, as what may be the first company ever to make enormous profits from this compound, if there's any room for a very small percentage of profits being redirected towards these indigenous communities from whom we've learned so much.
Excellent question. We are actually actively looking for ways of contributing to indigenous communities. However, our experience with nonprofits is that I guess maybe not our experience with nonprofits altogether, but I worked in medical philanthropy, and we've probably given close to $1 million personally to various mental health and psychedelic causes in various ways. We are looking for a meaningful way to make this contribution, to make sure that it actually does make a difference in indigenous communities. What is the system of measure, M&E? And how do we ensure that the funding is actually well spent? We all know about the misuse of funds in, foreign aid and things like that. So we are exploring these options. we also exploring the option of setting up either corporate foundation or share, give options or shares in Compass to foundation to boost psychedelic research. It all depends on kind of evaluating the efficiency and impact of such interventions, but it is it is on our minds.
I mean, to be fair to Compass, I do take the point about the indigenous communities, but Compass presumably haven't yet made a profit, and they've got a very tough pathway to negotiate. And I think there's clearly going to be benefit to, if you successfully negotiate that pathway, then there's going to be benefit to patients. And then, of course, we would, of course, be very impressed if you send some of your profits back to good causes elsewhere. But we're a good deal away from that at the moment, I guess.
Right.
Is that fair to say?
We will be about 300 million in
Yeah.
debt by the time if there is a marketing approval. But it's never too early to start thinking about it. These things take time.
Okay. Any other questions or points from the floor? Yep.
I guess we were talking earlier about the possible model for combining therapy with medicine and the financial constraints. What's the sort of, if you were to have a guess at what would be financially viable just now, what would the sort of number of sessions or the number of guides and so on look like? Or have you not got a clear idea of that because of the numerous sort of variables that we don't have a handle on just now?
Except for me.
I think, yeah, probably.
So I can start and see if anybody else has a better idea than I do.
Well, I can make a small point, but just about the British system. Obviously there's different systems everywhere. Our concern in the UK, or at least in England, I'm not sure I'm talking about the rest of the UK, despite my accent, is there's a block contract for mental health services. So you get a fixed amount of money, and if you want to create a new service, you have to take it away from somewhere else. Now that is clearly, and that just applies to mental health services. It doesn't apply to the acute trusts. So the acute trusts are a bit like my teenage kids with my credit card. They sort of run up a debt, and then the parents in the form of the Secretary of State comes and pays it off for them. If it's too egregious, the chairman gets chopped and they get a new board. But that doesn't have mental health, we have a block contract. And to my mind, that's very iniquitous, because developing new services is extremely difficult. You've got to take it away from somewhere else. So if I want to set up a psilocybin clinic, I would say, well, I'll have to take some money from schizophrenia services or from eating disorders or something like that. So I think that's very bad. Now, NHS England, to my understanding, is looking at new funding models for specific new therapeutic indications as a first step, and I think it's a long overdue first step for mental health. So it will reward innovation and get new treatment. And I guess there's a similar type of dynamic playing out in most of the socialised medical care systems. But it's essentially a bit of a political battle, actually. And one of the problems we find is that in Germany, for example, you've got to pass a benchmarking against a standard treatment. Now you think, what would be the standard treatment? And you've got to show greater efficacy and greater value for money compared to the standard treatment. And very often things fail because they're compared against standard treatments which may not have data on the same parameter that they have. It sounds very sort of complicated and abstruse, but so that doesn't get counted because the standard treatment. So the system is not fit for purpose in terms of rewarding the establishment of new services, I think. That's my view. How's it going?
Well, I think the other issue is that the economics drive so many of the decisions that are made, and we often don't have the necessary economic data to prove our point. I mean, one of the lessons is that if you're going to do pharmacoeconomic studies, choose expensive patients in whom you can actually make a difference. And most of the expensive mental health care falls on the family and falls on the society. So, 80% of the costs of major depression are not hospital costs. They don't fall in the budget of hospitals. So you're going to make a case within the hospital service. You're going to save money. You've got to choose really expensive patients. So one of the smart things that IAPT has done recently is to focus on the physically ill people with anxiety and depression. And hey presto, when you do that, you can actually show genuine economic benefit from using psychological intervention. And that's quite an important and instructive thing to have happened. And I don't know how we can learn from that in adopting the approach that we want to take with patients. But the difficulty is that our patients, in terms of the system, don't look very expensive.
Okay. Further questions?
Can I ask a question, Alan?
Yeah, sure. You've got one there.
Oh, yeah. So, I'm approaching it from the lens of seeing, looking at rescheduling from cannabis, and there's one drug example where a drug has been moved from Schedule 1 to another schedule, and it's Sativex. And the reason why GW Pharma took the route that they took is because it meant that they could it could fund their research, and they could kind of keep their patents on it. So what they did is that rather than attempting to just reschedule cannabis outright, they made a specific patented formulation that they could then reschedule whilst the rest of cannabis remained in Schedule 1. I'm wondering if the rest of the panel would be happy with that happening with psilocybin, so a specific patented example that was moved from Schedule 1 whilst the rest of psilocybin remained in Schedule 1, or whether that wouldn't be sufficient, whether you're actually looking for whole-scale rescheduling of the substance.
James?
I think it would conflate two issues, which is the medical use and the recreational use. I think we need to be careful not to conflate those just at the moment, because otherwise I think we get ourselves into difficult waters. Let's concentrate on the medical health-related argument, and that per se would mean the reformulation or the rescheduling of a formulation of psilocybin. But that then, if you like, acts as a bit of a beacon, I suppose.
I mean, one of the great drivers for trying to reschedule or liberalise the use of cannabinoids has been a service user groups. So, any thoughts about this?
Sorry, were you going to say something? No, you go.
Yeah.
We'll go around.
Sure. Yeah. Well, just to follow on from that, I mean, I don't know why there's a problem with conflating those two issues, because they're connected. And I think part of what I was trying to explore in my talk today was the ways in which, in medicalising, it changes perceptions of the non-medical use. And if that's the case, and to the extent that that's the case, these things should be considered together. And so, yeah, and I could give an easy answer to Henry's question because my talk was about it, which is that, yeah, I don't think I would be happy if it was just rescheduled, leaving all other uses of mushrooms or psilocybin as illegal. Like I think part of it is about the commitments that you start with in this well, I'd say in this world, but I feel like we're in different worlds, but in the shared space we currently occupy. And it may be a certain treatment for someone, or for people. It may be the medicalization of something that you think should be a medical entity, or it may be, for example, social and political injustices, like broadly. And if you're speaking on that largest level, lots of issues seem to connect up in ways that can be criticized for not having practicable, easy solutions, but they give a bigger framework through which to understand what it is that we're doing. And I agree with you, Katia, to recognize that we should have our commitments, this is my line, but to have our commitments up front as to what will happen with the enterprising or opportunistic kind of initiatives that we're embarking on right now. A lot of that, again, I think in relation to sort of the pharmaceutical world and drugs world you get into these tricky issues of kind of whitewashing, or trying to make your kind of brand with the ways in which you kind of engage in social justice work or whatever, with profits or however. But that's just part of the game that I suppose you're electing to play.
I don't really have any answers, just thoughts. So hopefully they make some coherent sense. I think for me the most important thing is that people that need access to this treatment get access to this treatment. So for me, if by patenting a formula or whatever was the way of people like me and Michael getting the help they need, then so be it. That's the way. I think that's the thing, isn't it? It's we're aware that this can really, really help people suffering from treatment-resistant depression. Yet we're several years away from the trials ending and then this coming to market. So I mean, in the very short term, okay, declassify psilocybin, so I'm able to go and pick some and take them at home. But there's a very, very big important element for me is the clinical setting, I think, or having the healthcare professionals around you. That for me is as key as the substance. So yeah, I don't know if I'm making much sense, but even if psilocybin was decriminalised tomorrow, would I go out, pick some, take some at home? I don't think I would take a risk, because I feel it's so important to have that help around me. So that in itself wouldn't, talking from a completely personal perspective, that wouldn't help me. Whereas a patented formula would potentially also.
I might not understand all the kind of intricacies of drug policies, but I think legalization is more relevant for substances like MDMA and LSD. For mushrooms, it's really decriminalization. And I think if we're talking about decriminalization and people going to jail for possession of mushrooms, then it's a no-brainer. But I think if we're talking about psilocybin therapy by non-therapists, knowing that patients are really vulnerable in this situation, they're highly suggestible, and I think when you're making a claim of being a therapist, you're making a medical claim, and therefore it needs to be regulated. So I do have a little problem with psilocybin therapy being legalized without kind of proper oversight until we know more how to do it. But I think the answer to this is more research.
Michael?
Sure. I can't add anything more than what they did, just to completely agree.
I mean, just to kind of explore that a bit more. I had 2 points and I've forgotten the first one. Please, do you want to?
Yeah,
I'll remember.
I was just going to pick up on, I guess, what the point Ekaterina was making, which is that you can grow mushrooms on your window, but you can't grow your own psychotherapist on your window. So that's the key problem, right?
Yeah, I think, as everyone knows, in Canada recently, cannabis was essentially decriminalised entirely. As I understand it, that's really stopped medicinal use of cannabis. So you may actually, by demedicalising it, if you entirely make it legal, you may demedicalise it. And I think one of the themes that's emerged from today is it's not just the psilocybin molecule, but it's also the context, the setting, and the combination with care, which is important. So you may actually throw the baby out with the bathwater, specifically for the medical use, if you make it totally freely available, which is, I think is what you were saying, Neil.
More or less. Yeah, I think so. Yeah.
I would completely agree that like just picking a bunch of mushrooms and taking them might not be a very good idea. I mean, I think I'm trying to remember the The paper lead-authored by Matt Johnson at Hopkins in 2008, which is on safety in using psychedelics, I think a lot of the examples that were drawn on were both indigenous use and underground use, as well as best practice from the 50s and 60s. And I don't know where the best practice from the 50s and 60s came from, but at some point down the line, things are going to stop being medical and they're going to be traditional in other ways, which is just to say there's a rich ecology that still exists today of very safe ways of making containers, of being with people, of doing a form of therapy. The medicalization of that, turning it into a medical space, and the putting of white gowns on the therapists, and I'm being flippant, but can often lead to harms as well.
It's just another tradition. I mean,
yeah, I mean, it's just another
it's
tradition.
a tradition that's worked very well for our longevity, if you look at survival in Western countries. So
It's also produced a lot of inequality, right? I mean, there's a lot of
how
ways
does
it
produce?
So how did it produce it? How did medical science produce inequality?
I mean, so to me, as I understand the medical model, it prices a lot of people out right now, and it always has. I mean, if anything, I think with the National Health Service, this kind of socialized approach to medicine, it may have come and it may be going again. But the way in which medicine, as a big institution in our society, partakes in the creating of more inequality, I'm talking about economic inequality primarily, I find that not only would I stand by that, but I'm not sure
Just
that
explain how we create inequality by having a health service. That's just a curiosity.
Well, no, I mean, not the National Health
Service.
Yeah.
Well, that's the only one we have.
Yeah,
it's been there since 1947.
And where's that going?
As far as I know, we're still spending as much on it as we did. In fact, it's gone up.
Yeah.
And it's estimated to be 40% of GDP by the end of the decade. So,
I'm not to say that we're not spending money on the National Health Service, but just that the increasing rate of privatisation of the health service.
but that's a completely different point. I mean, that's about service provision. It's not about who pays for it.
Well, this is perhaps an argument that can go on, but let's just have another question.
Sorry, could I just add the underground therapy as well? I don't think you're talking about a minimum of $500 or £500, as you said. I mean, I know people who do it on a sliding scale. So I just think there's a lot of integration of social justice into a lot of the work that is done in the underground, which, like I said, I think is kind of often quite careful work as well.
Okay.
Listening to all of this, I get the uncomfortable feeling that we may be targeting the wrong area. Why don't we use the system to help us? In other words, we're targeting treatment-resistant depression, which we say most of the cost falls on the family. Why don't we also target things like anorexia or OCD, for instance, which are costing the NHS a lot of money? We could save money possibly by doing that.
Yeah, I mean, you actually can obviously see into my mind, because I was thinking, out of the possible large number of choices of which of these illnesses to help, which ones would we go for, which way? And remember, drug development often comes up with unexpected, totally unexpected benefits, if you want to call it that, Viagra, for example. So, I mean, we do have a number of people in the audience who are interested in things that aren't treatment-resistant depression. Anyone want to comment? Janet?
Yeah.
Our world expert in anorexia. Do you want to hand the microphone back to Professor Taylor?
Well, you're right. I mean, perhaps anorexia is one of the most treatment-resistant conditions, and so we haven't been looking for anything different than Gold did 120 years ago.
Well, you saw what Robin said this morning.
Yes. Yeah. So the phenotype is very much fitting with what Robin says. Okay. Yes. Carol, I'm hoping is going to. Okay, what you want to say, Carol?
Yeah.
Yeah, I mean, I think what we're seeing increasingly is, unfortunately, a predominance of mental ill health problems in people up to their 50s and 60s, because population-wise, we've actually been much better with dealing with cardiovascular disease and skin heart disease. I mean, I think certainly for European socialised medicine, it's been a great agent against inequality, going back to John Snow. But I think if we think about the big burdens, they are these chronic, intractable
diseases which tend to onset in young, early adulthood. And I think we should have the leeway, we should have the flexibility to actually think about new treatments in new areas in an experimental way. A bit like, Robbins, I can't see Robin, but a bit like the Imperial team, James and Robin and so on, did with treatment-resistant depression, which is still actually amazingly managed to do that, Dave Nutt and so on. I mean, you would bet quite a lot of money against that not happening, I think. But, why can't that happen with anorexia or childhood onset OCD or whatever? And the reason is the system isn't flexible enough to support it or allow it. I don't know, any of the panel want to comment?
Could I just,
sure.
no, it's back to you, it was a question back to you.
Oh, right. Well, do you want to say it so they can hear you?
Yeah. It was, you can't see that happening, or you can't see that happening for a while. I mean, is there a sort of...
Well, I think it is beginning to happen. I think it's happened to TRD. I think we've now got a company that makes psilocybin. I think there's now a community that's advocating for this. I think the users, the service users' voice, the community's voice is actually incredibly powerful. And I think if politicians are much more responsive, the thing, without sounding too much like I'm against the medical model, sometimes the medical science is very conservative and needs to be nudged so it can change and take account of things. But there's certainly a huge need for change, and voices added to this are extremely important.
Yeah. As well as the lack of efficacy and existing methods of...
Well, I mean, I think existing methods for lots of things work in a range of efficacy, but there's absolutely no doubt that with lots of these areas it could be a lot better. And as Janet says, she knows much more about anorexia than anyone else, and you're saying there's a huge gap there that needs new treatments to come in. Yeah.
But I mean, it relates partly to your thing about block contracts.
Yeah.
That if you wanted to innovate in anorexia, you find it very difficult to get the necessary resources to do it. Wouldn't that be the case?
Well, except inpatients, NHS England, so they're a bit separate.
Yeah, but I mean, the principle is there. It's really quite difficult to say, right, from now on we're going to try this out.
Yeah.
In a sort of open label, let's suck it and see, we can't do much harm, and these patients are untreatable in other ways. That would be very difficult to do.
I was just going to add to talk about broadening from beyond depression to kind of other indications, but I mean, there's an interesting business case to be made for, and as was kind of raised earlier, extending it even wider, so it's kind of preemptive. That's not going to be done on the NHS certainly, but the idea that that could be provided privately and the value that could actually make to a wider society is an interesting one to kind of play with.
Yes, indeed.
I also want to mention that if we think about new indications, again, going back to the math and how to do it, to develop the drug, if you have the drug, to develop it for a particular indication to take it through phase 2-3 is about between 100 and 300 million pounds. So if tomorrow there is a pilot of psilocybin for anorexia published with positive results, there will be no investments, no resources in developing psilocybin for this particular indication because no use patent, again, can be filed. So in that sense, I would say the open science or anti-patent stance is anti-access stance. And part of the reason why Compass hasn't signed an open science statement is because the word patients has never mentioned in this statement. So we understand the path to patients and what it takes and where resources come from. And that's the way we do it. So I think it's important to keep in mind what, in practical sense, what it takes to develop the drug for a particular indication and build it into the health system.
Right, we've got about 2 or 3 minutes left. What I'd like to do is just give anyone on the panel an opportunity to say a final closing statement, and then James will wrap up the meeting. So anyone else from the panel want to pick up on anything? Yeah.
Thanks. Well, just to say, I mean, I find the numbers really extraordinary, and it must be really hard working with such a scale. But I think about the shoestring budget that a lot of decriminalisation, harm reduction organisations work with, and I think that discrepancy is massive. And so there's a lot of good work that can be done. I think a lot of good way of thinking about science often is that it's about resources that are scarce. It's sort of money, it's attention, it's time. And if we're interested in using our scarce resources to affect greater change, then these are other avenues that should be considered.
Okay, James, do you want to wrap up?
Yeah. How to do that? I was thinking about the fact that the clinical trials process arose out of largely the thalidomide tragedy. So in a sense, it's driven by society. It's driven by all of us, and it's necessary. I do think it's absolutely necessary, and that's what we're doing. And I don't know whether it will work, but it feels to me to be one of the most interesting and exciting things I've come across in my career as a psychiatrist, which is not that long, but it's not that short either. And for that reason alone, it's an interesting ride, and the reason why I keep doing this, and why I sort of stick my head above the parapet a bit. And I'll close slightly, and I suppose we're all doing that in a way, and we should all congratulate ourselves for that, because that is how change happens. When I was a registrar, I wrote an article in the BMJ that I originally wrote with David Nutt, but they wouldn't let me publish it with David Nutt because they only let you publish opinion pieces under one author. So I kept the authorship, and this article came out. And I was on nights at the time, and I got called from Radio 4, the Today programme, saying, "We've seen your article, please can you come on the show tomorrow? 6 o'clock in the morning, we want to talk about this." I said, "No, I'm on nights." They said, "Well, we'll send a radio car round to the hospital so you can come out and talk to us about it. You're really on this." And I said, "No, I'm sorry, I'm not sure the medical director would be happy if they realised that's what was going on." Anyway, this article went round the world. I think someone put Allan put stuff earlier actually.
Sure, slide.
Yeah, it was. We all copy of each other. And it just it showed to me that this research in this field and this whole area is like a jack in the box, and you just apply the slightest stimulus and all sorts of odd and unpredictable effects. But that happened. But that represents the fact that society wants to talk about it. And we are, and we're contributing decent data to 2 key questions of drug development. Is it safe, and does it work? And that is a good thing, I think. So I will think end there.
Okay, I'd just like to say a couple of things. One is to say that National Institute of Health Research is sponsoring this research as well. So obviously, Compass has got a trial going on, a health volunteer study that NHR is sponsoring a trial, which is undergoing. So that's actually the British government, I suppose, if you want to use such a dirty word as the British government, which is sponsoring that, which I think is a good thing. I'd like to also just do a brief vote of thanks. I'd like to thank all of the speakers and participants. And just hold on. And before you get to that, I'd like to particularly thank James, Catherine, and the team for putting this day together. I think it's been marvellously interesting, and hopefully will be a springboard for the future. So let's thank everyone concerned.